Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm continuing to talk about rheumatoid arthritis. When I left off last week, I talked mostly about the different symptoms of rheumatoid arthritis and how one has to be careful because arthritis is not just always arthritis, that sometimes arthritis is the first sign of other significant medical problems that not yet evident, but the first present with the symptom of joint pain, etc. I went on the internet, I got some of the statistics for you. Again, as I mentioned, rheumatoid arthritis, 1.3 million adults in this country has rheumatoid arthritis, and 294,000 juveniles have rheumatoid arthritis. There are also different types of arthritis, as I mentioned. I'll list them to you so that you could also get the statistics. Spondylitis arthritis, 2.4 million adults have that. Lupus-associated arthritis, anywhere between 320,000 folks and adults in this country have that. Systemic sclerosis, also known as scleroderma, 49,000 adults have that in this country. Something called Sjögren's syndrome, which is very common, 3.1 million folks, adults have that. Osteoarthritis, as I spoke before, some 27 million adults have that in this country. Polymyalgia rheumatica, which is another form of arthritis, 711,000 folks have that. Something called giant cell arthritis, which is very, very important and very common, 228,000 have that. And gout, 8 million people have that. Fibromyalgia, 5 million people have that in this country, adults. Carpal tunnel syndrome, which is very, very common. Some 10 million people, believe it or not, have carpal tunnel syndrome. Low back pain, which is associated with all sorts of conditions, especially arthritis. 59 million people suffer from low back pain. And then neck pain that people have all the time, myself included. 30.1 million people suffer from neck pain. Now, I want to give you an idea what that means economically, because I went again and check it out and get some of the money statistics for you. The state of California, $12.1 billion are spent on arthritis of different type. New York, state of New York, 8.7 billion spent on providing care for arthritis. Texas, state of Texas, $8.7 billion spent providing care for arthritis. State of Florida, $7.6 billion. Pennsylvania, $6.5 billion. Ohio, $5.7 billion. Michigan, $5.5 billion are spent every year on arthritis care. North Carolina, $4.1 billion. Georgia, $3.9 billion. New Jersey, $1.5 billion. This have a tremendous economic toll on these different states because some of these people, they just cannot go to work. They're suffering so much. So again, getting back to osteoarthritis itself, we're now going to try to see how to diagnose it. Well, somebody comes in, they're having pain in several joints or one particular joint, and you talk to them about it. You take the history, the family history, very important. The work history is very important because the pain may be associated with work-related injuries, etc. Professional activities, very, very important, depending on what you do for a living. One particular joint, like if you're a pitcher, your elbow, your wrist, your shoulder, your knee, your backs are very much involved in trying to throw the ball. If you play football or soccer, all these different, hockey, and all these major sports, you could be suffering from arthritis related to these different sports, etc. That goes without saying. So that's why the professional work that you do is very important. If you drive a cab, if you drive a truck to make a living, or if you're a construction worker, you're constantly lifting things, doing stuff, using the jackhammer, all these things are very, very important to know when you're taking the history. The sex of the individual, female versus male, Very, very, very important. Okay, and there are people whose family has had arthritis, and now they're suffering from arthritis. How old were the parents when they have arthritis, etc., the siblings, and so on and so forth. It's very, very important. So suffice it to say, arthritis is a very, very common problem. Osteoarthritis being the most. 600 million folks have osteoarthritis across the world. So now that you've done all that, then you're going to, of course, examine the individual in question. Very important you pay close attention to the joint in question. How mobile is the joint? How flexible is it? What happens when you extend it, etc. Is it swollen? Is it tender? Is the skin is red, etc. And then remember, rheumatoid arthritis is a systemic disease. That means that multiple organs can be affected at the same time or at any one time, from the skin all the way to the brain, the heart, the lungs, the GI tract, the kidneys, etc. This is an autoimmune disease. And I explained what an autoimmune disease is the last time. There are hundreds, if not thousands of them across the world. It has to do with something that is the body itself reacting against it, when meaning that the body has an antibody, an antigen in it that forming a complex that results in an antibody. And now the antigen-antibody complexes exist, and wherever they get deposited, that then causing a local inflammation, which can become diffuse, etc. We don't know what causes most autoimmune disease, and we don't know what causes rheumatoid arthritis, which is a common disease, and it's very, very common. We still don't know what, of all the knowledge that we have, and believe me, you have rheumatological research going on throughout this country, throughout the world. No one is able to figure out what really is the cause of osteoarthritis. Another disease that's not listed there is, of course, sarcoidosis. Sarcoidosis is also very commonly associated with joint pain. People don't realize that. Don't realize that. I gave a little history, and I'll repeat that history. When I was a student at Montefiore, I took a radiological elective at Montefiore. So when I got there, the first week I got there, I think it was a 6 weeks or 8 weeks, whatever it was that I was supposed to be there. In front of the door, as you enter into the radiology department, there was a box and a little tablet with some description of a medical issue associated with whatever the problem was, and you were supposed to be read it and then drop in the box what you think the diagnosis is. Well, you have to understand, I think I was a fourth-year student. That's right, fourth-year student at that time, because I had already finished all my required rotations. And so I took a little 4x4 card out of my pocket, not knowing what I was doing or what I was talking about, and I write sarcoidosis and put it in the box. I had never seen or heard of sarcoidosis. I just read about it and as I was doing my medical rotation. It turns out that this particular case had been there for months. And every passes, every day, nurses, doctors, passing students, you're supposed to stop, read the case history, and put that thing there. Little did I know, it turns out to be correct. I was correct, but it was a bone thing. Now what happened was a crucial fact is that Dr. Jacobson was a world-renowned bone expert in X-ray. And there was a gentleman from India called Subi. We called his I don't remember his full name, but his regular name, but his name that we gave him was Subi. This guy was a genius. He used to write a section on JAMA that used to come once a month or one, I don't remember. And he also was a bone expert. I knew nothing about this until I subsequently met Dr. Subi, we call him. This guy was absolutely brilliant. So, but my preceptor was Dr. Sigelman. That's right, Dr. Sigelman, who was an internist and gave that up and went into radiology. Brilliant internist, brilliant radiologist, who subsequently left after Montefiore and went to Johns Hopkins to run the X-ray department. He was a brilliant teacher. I learned a lot from him. So it turns out that the reason why it was sarcoidosis of the bone because M.A.C.P was the one who wrote this up and put it up there. And M.A.C.P was a world-renowned bone X-ray expert as well. That's how he rotated at Montefiore because of his connection to Dr. Jacobson, who was also a bone type thing. So therefore, and subsequently in private practice, I myself have diagnosed several patients in my practice with sarcoidosis of the bone. I have example in this book here. Let me show you the book, African American Men's Health, which I wrote. There's the chapter on sarcoidosis. I put some bone x-rays there that has to do with sarcoidosis of the bone. That's right. Sarcoidosis is another disease of autoimmune disease that affects mostly Scandinavian women and sometimes men, but it's more common in women. It also affects women more in this country than men, but it's devastating. It can cause the eye problem. A lot of the time people present to the eye doctor with eye problem. It can cause, it's because of sarcoidosis. That's one of the things they evaluated. It can cause severe pulmonary problem. That's of all the terrible problems that it can cause. Most people die from it because of a pulmonary problem. And here, in the list that I just gave you, let me show you another condition that is frequently associated with sarcoidosis of the eye, and it's called giant cell arteritis. That's right. Whenever you see somebody having this recurrent eye problem, you must think of the possibility of what we call giant cell arteritis, okay? And that has a connection with sarcoidosis as well. And the eye doctors are very familiar with it, and they're on top of it. That's one of the diagnoses that cannot miss. There are many, many diagnoses that cannot miss. Among them is the so-called temple joint arteritis, which can affect the eyes. So therefore, when somebody comes in with eye disease, it may not just be eye disease alone. You have to think about these things, because if you examine the patient, you have tenderness in the temple area. You must think of a temple arteritis that's causing the problem that can affect the eye. I mean, these are stuff. This is a diagnosis. If you missed it, it doesn't take very long for the patient to lose his or her vision, okay? But the eye doctors are on top of that. So this is what I say. These are systemic diseases that can affect all sorts of organs. So sarcoidosis, even though it's not listed on this list, is very common. In this country, it's more common in black folks than other subgroups. In Scandinavia, it affects mostly Scandinavian men and women, but more women than men. Okay, so, and several people of note in this country whose name I'm not liberated to mention have died because of pulmonary sarcoidosis. Okay, so this is serious business. That's what I'm saying to you. When somebody presents with joint pain, you can't have a tunnel vision thinking it's just arthritis. It may be a lot of other stuff, and if you keep ordering this test, that test, if you don't know what test to order, by the time somebody else get a hold of the patient, then suddenly you've been accused of missing a diagnosis that was obvious to somebody else but not to you. You got to be careful. If you're not sure, refer the patient to a rheumatologist. These folks are superb at what they do. It's a subspecialty, and they're on top of it. They only see patients who have rheumatological problems. They're very good at it, 24/7. They'll take over the care of the patient, evaluate for you, and then make a diagnosis. Okay, so now that you keep these things in mind, you finish with your diagnosis. You finish with your evaluation of the patient, physical examination. Now you're going to have to order blood tests, an X-ray test. But the first blood test you're going to order, obviously, is a complete blood count, followed by a complete blood chemistry profile, And then you're going to order a steroid, crucial. Then you're going to order a rheumatoid factor, that's crucial. Then you order an ANA, that's crucial. But at the time you're ordering the ANA, you must remember also to order an ENA, okay? Extractable nuclear antibody. Now, the thing is, in the old days, they used to do the ANA, the ENA just to separate the Smith antibody for some. Not now. Now you're going to have a page long of all the different subgroups. Just check off ENA. You can get a page long of all the other things that they can pick up that can be associated with all these different, most of these different diseases that I mentioned to you. But you have to remember to order the ENA. If you order the ENA, for instance, if you want to diagnose Sjögren's syndrome, all the antibodies that can be associated with, they're all going to come back from the lab, because now they don't do just the 2 tests we used to do in the old days just to separate the Smith antibody, blah, blah, blah. Not anymore. Now you're going to have a page long. But you got to remember, you have to know what an ENA is in the first place to order it. You get your steroid, you get your rheumatoid factor, you get your ENA, because remember, several other problems present with arthritic symptoms as the first manifestations. Okay, so then you order urine analysis. Okay, very important that you do that. You order urine analysis so that you can get a look at what's happening in the kidney this way, under the microscope. Okay, now that you're done, you order a uric acid as well, because the patient may have gout, and you don't know. They may not have history of gout. I was just telling somebody a couple of days in the office, it is, the way science is, it is fascinating. There's an enzyme. It is a long name enzyme listed in this book under the chapter on gout. I'm not going to repeat it to you right now. If you're missing this entire enzyme, you are homozygote. You were born from your mom and dad missing this enzyme, you're going to be born retarded. That's it. All the kids will be retarded, and they're usually lying in a fetal position, self-mutilating themselves all day long. If you miss the entire, if you're homozygote. However, if you're heterozygous for that same enzyme, not only that you're going to have gout, and most of these people are extremely intelligent. Now you figure that one out. Only God can tell you why. Why, if you're missing half of it, you become very intelligent, you have gout, because most people with gout are extremely intelligent. You go back in history, you just name the name of the folks in the history that did a lot in this world to make the lead. People who created the telephone, the Churchill of the world, the Benjamin Franklin, all these folks had gout, and they were super intelligent. But they're missing, they were all heterozygote for this enzyme. When you're homozygote, not only that, you're completely mentally retarded. How do you figure out? If you're missing half of it, you have God, you're very intelligent. If you're missing the whole thing, you're completely retarded. You go and ask God about that. But I just thought it's a point to tell you how fascinating science really is, okay? All right, so now, so you do your uric acid. Very important you do that, okay? And you get all this stuff done together. And then now, you're going to try it off. So it's very important to order a ferritin. Yes, super important to order serum ferritin, because serum ferritin, when you have any one of these autoimmune diseases, these diseases are also autoimmune/inflammatory in nature. That's right. You can't have this arthritis without having inflammatory processes going on at the same time. So the more inflammatory processes you have going on, the more you're likely to have secondary hemochromatosis, which wind up being a double whammy, because hemochromatosis itself, primary or secondary, will ultimately cause you to have arthritis, because the iron is going to deposit it in many places in the body, including the joint. And once the iron sits in the joint, no matter the reason why the iron got there, it's going to cause a local inflammation itself. And once the iron sits there, it has to release all sorts of garbage, And all these things cause a local inflammation. And you wind up having arthritis on top of that. So the ferritin is very important, super important. All right. And then you start ordering your x-ray. You start with a plain x-ray. And then you follow that with a CAT scan of the joint in question. Then if you're still not satisfied, then you do an MRI, because the MRI will tell you what's happening inside the joint, not just the bone itself, but all the tendon, all this other stuff, things that are ruptured and this and that. You'll be able to see all that. Now, if the joint happens to be has a fusion associated with it, then you have another work that you have to do, because you're going to have to tap the effusion. That's right. And I went through that when I spoke about osteoarthritis the last time, and I'll discuss it a little bit again. You tap the joint, and then you have to know what to do with the fluid. Not only that, when you remove the fluid, depending on how much it was, it's going to provide some relief for the patients in terms of the pain, but you must separate the fluid in three separate parts. First, you have to look at it. Is it yellow? Is it cloudy? Is it bloody? You need to know that, a combination thereof, very important. Or how much did you take out, and so on. Then you send part of it to the hematology lab to have cell count done, very important. Then you take part of it, you send to the chemistry lab to have protein done, glucose done, and crystal. Very important, okay, because if you look for crystal and you find crystal, then you, depending on what type of crystal it is, it may be gout or pseudo-gout. If it's in a woman, you find certain type of crystal, then it's probably going to be, negatively by infringing urate crystal, that's pseudo-gout. And then if you have sodium urate crystal, that's likely going to be gout, and so on and so forth, okay? Or calcium pyrophosphate, which I still remember all this stuff. That's what you get in gout. How do we know what crystal it is? We are trained as medical technologists to recognize this crystal. That's why it's experience. Then you take part of the fluid, you send it to the microbiology lab. What are you looking for? You're going to do a gram stain to make sure there is no infection right away, because you could smell it within minutes and see if there are microorganisms with gram stain, and then you culture it. So that's what you do with the fluid. Very important, okay? Doesn't matter what the underlying arthritic condition is. That's how you handle the fluid. That you can't check the fluid and throw it away. That would be ridiculously bad if you don't do that, okay? So now that you've done that, and then if the patient needs immediate care from an orthopedic surgeon, you're going to call the orthopedic surgeon right away to provide immediate care to relieve the pain and the joint and so on and so forth. But you, now that you're waiting for all your stuff to come back, your task as an internist or a internist rheumatologist, because all rheumatologists are either pediatrician or internists themselves who subspecialize in this stuff. So they know not only rheumatology, they also general medicine. And all general internists, such as myself, who are teachers of clinical medicine, know this stuff inside out. Because not only we have to practice it, we have to teach it to students, we have to teach it to intern, resident, fellow, whatever. We have to do that. So therefore, we know that stuff the same way we could load the palm of our hand, okay? And we have to know it from the top of our head. You can't just pick up a book and walk around the hospital with the book in your hand and look it up when you need something. You got to spill it out right away and provide for the patient, okay? So now that you know how you're going to sort things out, and now that your stuff is coming back, if the rheumatologist, if the blood count come back, is the patient anemic? What? Very important, because all sorts of arthritis are associated with anemia of one type or another because of the inflammatory process that all these arthritic problems are associated with. You can't have chronic arthritis of any kind and don't become anemic because of the inflammatory process, and I went through that last week, why the transferrin protein is not able to overcome the block to deliver, to grab the iron and then deliver it to the bone marrow. That's why, because, and then of course, some rheumatological problem, you may also have hemolysis associated with it. How about that? So this stuff is super complicated. If we're talking about rheumatoid arthritis, you may have Felty syndrome. Felty syndrome is something that is associated with rheumatoid arthritis, where the spleen becomes enlarged. Once the spleen becomes enlarged, you're going to wind up with low white count, low platelet, and some form of hemolytic anemia, because the spleen is going to have to swallow up the red blood cell. This stuff is fascinating, but it's also complicated. So it's very important that you ordered an abdominal sonogram and or CAT scan, plus your exam of the abdomen, to make sure that the spleen is not enlarged. And we're talking about rheumatoid arthritis, and you go from there to doing a CAT scan of the abdomen, because you're looking for Felty syndrome. But if you don't know what Felty syndrome is, you never heard of it, how are you going to do all this stuff properly? You can't. Then your job then is to refer the patient to a rheumatologist who knows these things inside out, and he or she will do these things. But if you're a general internist, in particular, if you're in a teaching business, and see, you have to understand, academic general internist is not the same as general internist. Come on, I don't need to tell you that. You know that, okay? This is not to put down anyone that's doing general medicine. No, but they didn't commit themselves to teaching. And those of us who commit ourselves to teaching, frankly, we are better at it, and we are more up to date. That's no knock on anybody else. Listen, I'm going to stop here. Next week, I'll continue again talking about rheumatoid arthritis. Until such time, keep watching this show. This is Dr. Alcena saying so long and bye-bye.